Okay, so you've heard lots about antimicrobial resistance. We've heard lots, hopefully, about new things sort of coming through. I'm going to talk a bit about either carrot or stick to try and sort of make some of these sort of things happen. I do 1 day a week for NHS Improvement as an antimicrobial resistance project lead. This means I'm involved in helping setting the sequins and the quality premiums that I'm going to tell you about. Since I've taken this role on, my Christmas card list has shrunk away to nothing. I almost get hate mail in the terms of sequin queries on a regular basis. So I'm going to try and talk you through some of these bits. So you've heard all of the various elements around the positive benefits of antimicrobials, how much they have added to life since they've been around, and it's made possible for us to do very complicated surgeries, organ transplantation, and keep a lot of babies and adults alive who are critically ill. If we lose the antibiotics, we may well lose the opportunity to do these things. If we look at resistance across the world, we've been touched on by a number of the speakers so far, you can see it varies considerably, and you can see high levels of resistance, Klebsiella pneumonia, example here, in India and South Africa to various common antibiotics on here. But people wrongly think that it's probably due to overuse in some of the lower middle income countries. Actually, they're fairly lowish users of antibiotics. It's the rich countries who go and see the doctors for any slight sniffle and everything else that we've got. And that's why behavioural change is such a major element to all of this. You've heard everything about the causes of antimicrobial resistance so far. I won't really say much about patients not finishing their treatment, but that would be one of the things that might change in the future on there, but everything else still stands. But the most important thing is no infection, no need for antibiotics, hopefully not spreading resistance further. Let's wash your hands. I go into the toilet and I'm appalled by the ability of males not to wash their hands. It's how you can wash your hands without not actually having a bit of soap and actually only getting the tip of your finger wet as you waft through. Beats me. So your challenge is, every time you see somebody not doing it properly in the toilet, challenge them, okay? I don't know if I did this last year. Why is it important? Everyone stick your left hand up. Just lean across and just pop your fingers into the mouth, and the person left take a big long suck, because every time you touch everything and then you eat that food, we've not washed our hands, you are literally sucking someone's fingers. So that's why hand washing is important. Okay, so you've seen all this. Potentially we might have 10 million deaths a year by 2050, more than cancer, equals one patient dying every 3 seconds. We've already heard from some of the other talks about the thousands of extra deaths per year across the world due to a lack of effective antibiotics, millions of extra hospital days, and billions of dollars or euros in actually treating some of these sort of elements. We know that it's probably going to be one of the largest threats to humanity, and in September last year, United Nations declared that they were going to rid the world of drug-resistant infections or superbugs. And in fact, that statement is probably even funnier than the rat in the toilet story we've heard, because that is not going to happen. So in 2 years' time, when they come back, let's hope we've tried to steady the rise of resistance, but we're certainly not going to get rid of them. We've already heard from Neil at the beginning about the 5-year sort of strategy, improving sort of knowledge and understanding, looking after what we've got already, and certainly stimulating new diagnostics, antibiotics or alternatives, as we just heard, out there. We have this 5-year strategy that we've heard about already, and the bit I'm going to focus on is really about optimizing prescribing practice, looking after what we have already. We already had lots of tools in place. We had antimicrobial stewardship guidance for hospitals. We had it in primary care that offered guidelines, audit tools, education. It was endless. However, look at the top right-hand side. Despite all these lovely things that we've had in place already, consumption of antibiotics in primary care, because we didn't have any secondary care data until probably a few years ago, is just going up and up and up. And so we've got a problem. We've already seen the data. 3/4 of antibiotics are used in the community. Um, um, just over 10% hospital inpatients, and big forgotten area is hospital outpatients and emergency departments, 5% in dental practice. Are there any dentists here? Yeah, excellent. The campaign they're running, and toothache doesn't need antibiotics, brilliant. It needs to be sort of spread out there and really shared. And so any new community pharmacists might be here. Wherever we go, let's share that brilliant campaign. We know that 1 in 3 patients at any one time is on an antibiotic in hospital. We know that 1 in 3 patients will have a course of antibiotics in primary care every year. So there's lots of antibiotics being consumed. Back in 2014, the Antimicrobial Resistance Advisory Committee to the government said, we're making some recommendations to reduce the total amount of antibiotic consumption back to 2009-10 levels. We want to reduce the amount of broad-spectrum antibiotics, because that's what's driving resistance, mainly in primary care. In secondary care, we want to turn back total antibiotic consumption by 3% by last year, 5% by next year, and also reduce the amount of carbapenems we use, because we've seen growing amounts of carbapenem-resistant gram-negative organisms. So what's been happening those few years? Well, we didn't have many nice infection guidelines sort of out there, but we've now got antimicrobial stewardship guidelines that have come in, and they've got quality standards that apply to primary care and secondary care. We've seen the two nice ones out, one about the processes, so we've all got to have stewardship programs in place, and only just earlier this year, we've seen out the changing risk-related behaviour in the general population. What does this mean? This means we have to tell the public about antibiotic use, minimising their demand for antibiotic use, educating children about infections and preventing it, and making sure that we have better hand hygiene and food hygiene and things like that. And from July, we're going to see NICE are going to have common infection guidance coming out, 1 a month. We can have sinusitis out first, followed by sore throat, followed by UTI. They're going to be quick, they're going to be usable, they're going to include diagnostics. They're going to be the tools we need to use. The other really important thing that came along was the Health and Social Care Act. Code of Infection Prevention Control was updated to include antimicrobial stewardship. The CQC will be looking at when they're coming to register and renew the licenses of all hospital GP providers, and we're working closely with them at the moment to give them a checklist to ask questions about what they should be looking for to making sure that stewardship is happening in all areas. So, a bit about incentive schemes then. Two sorts. Quality premiums are aimed at primary care. We spend about 90 million a year on these, and it's about improving the quality and services that CCGs commission, clinical commissioning groups, improving health outcomes for patients and reducing inequalities and hopefully increasing access to service. And with about 50 pence per patient, so it's not a small, insignificant amount of money. We have Sequins, which are commissioning for quality and innovation, and that's about 350 million for England a year. And again, these are about driving clinical quality improvements and driving transformational change. And again, trying to reduce inequalities and improve the outcomes for patients. And this is done by top slicing the current budgets available in the tariff system, and then if you meet the targets in there, you basically get the money. So, have we had a few? So, we've had quite a few related to antimicrobial resistance. So, in 2015 to 17, we've had a quality premium for antibiotic prescribing in primary care. And for the hospitals, we've had one on sepsis, antimicrobial resistance, and I'll actually share some data with you over the next few slides. And then for the next 2 years, we've actually got a sequin in hospitals where we've merged antimicrobial resistance and sepsis into this, reducing the impact of serious infections, and then a quality premium this year, which is about reducing gram-negative bloodstream infections. I'll tell you a little more about that. So, what have we achieved so far? Well, the first year we actually had, we set a very, very easy to achieve target to reduce antibiotic consumption in primary care by 1%. And we sat in a room and we said, what figure should we choose? And actually, we chose 1%, partly because it was achievable, but we knew we would actually achieve an awful lot more. And lo and behold, we achieved 7%. And that's what we thought we would truly achieve, because Scotland had done the same. So a 7% reduction, which is just over 2.5 million prescriptions, and 11% reduction in broad-spectrum antibiotics, which is great news. And that's been reverberated around the world as a really positive sort of impact. So let's focus a little on hospital. So we've got Start Smart, then Focus. So starting smart is about treating sepsis, so the sickest patients, identifying they've got sepsis, treating them quickly. But then, when we get something back from the lab, because hopefully we sent all the right tests off, is then focusing what we've got back on and trying to get them off the very broad spectrum antibiotics onto something not so broad, or even stopping if we don't need them, to try and prevent overuse and driving resistance. So quite simple. However, the sepsis sequence in year one, which was focused on emergency department only, actually increased the use of IV antibiotics in emergency departments by about 20% per year. So while we thought we were doing good, we actually drove increase in antibiotic usage and have probably impacted on resistance. On the right-hand side, it shows how we're doing currently at the moment, because in the second year, we built a day 3 review in to make sure people were reviewing things, not just starting antibiotics. And you can see roughly 2/3 of patients are actually getting an antibiotic in a timely manner. And the reason we chose antibiotics within an hour, it was just the easiest to measure element of the sepsis bundle. And so if you think about blood cultures, urine output, fluids, antibiotics, lactate measurement, and oxygen, and source control, so buffalo source, that's how you remember what's in a sepsis bundle. The good news is we've actually seen a reduction of 4.5% in deaths from sepsis. So there's a real positive benefit that's come from that. So that's good news. However, if you look about, now we've got some data we can send through to Europe, you can see that actually we're not doing overly well. This is antibiotic consumption. In this column here, that's the UK per head of population. We're the second highest in Europe, and we haven't really made any huge sort of progress. Overall, for hospitals and primary care together, we have moved 3 countries to the right, which is good news. So we're actually reducing our antibiotics. So the quality premium that we had last year, and you might think, gosh, how many ways are there to try and present data to make it look very positive? So this is from a friend of mine who said, how are we doing in primary care? And she said, well, it depends how you look at it. So overall, the total antibiotics are probably roughly the same. I think that's the general thing to say. However, our broad-spectrum antibiotics have continued to reduce, again, by almost 10%. So year on year, we've almost seen a 10 or-ish reduction each year. So that's good, and that will have an impact, hopefully, on not increasing resistance. However, there's massive variation in primary care. So this complicated graph here, along the bottom axis here, is the number of prescriptions per star PU. Star PU is a weight and sex adjusting way of measuring things to try and iron out the differences between those with much older people. And then on the vertical axis is, he says, you find the button, is the percentage of prescriptions which are broad spectrum. And we're trying to get beneath 10%. So this is the magic line, beneath 10%, and this is the magic line at 1.161 prescriptions per star PU. The bottom line is, if you're in this quadrant here, you're doing really well. You've achieved everything. If you're in this quadrant up here, you've got work to do. And you can clearly see there is work to do. And then I've managed to pull out here what's happening down in the southwest. And you can see Kerno here, just in the right bit. So you're doing some good stuff. So excellent. Keep it up. And this is a map of how people are doing, who've met the various sequence. So green, they've met both. And purple, they've not met the total antibiotics. Blue is they've not met the broad spectrum. And if you're red, and thankfully very few of them, these are CCGs who've met neither. And then on the right-hand side is the equivalent version for GPs. So I think it's pretty good. So we're actually meeting some of those sort of targets. Okay, what about hospitals? So I've just told you hospitals, we use buckets and buckets of antibiotics. So we set a target for antibiotics for a 1% reduction in defined daily doses. Let me tell you what that is. A defined daily dose, it's a WHO assigned